I'm Peggy O'Kane, president of NCQA. I founded NCQA 35 years ago. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. That's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. These conversations are for people who are curious and want to help the U.S. escape bad health outcomes and runaway costs. This is Quality Talks. Our guest today is Dr. Rita Redberg, who is, to me, a pioneer in the field of cardiology, but I think on broader issues about where does our healthcare dollar go and where are we getting benefits, and sometimes where are we getting harmed by healthcare dollars. And if you figured out that she's a courageous woman, you're exactly right. This is a difficult topic because I think ideas of what constitutes the standard of care often are kind of cultivated in particular ways by particular areas of medicine that are kind of related to what they do. It's rarely a simple issue, and yet I think waste and harm are some of the biggest things that impact our collective health and our collective spending. Rita has written a series called Less is More, and when she was, for 14 years, the editor-in-chief of JAMA Internal Medicine. And Less is More I think it's not only not popular among many physicians, but it's unpopular often with the public who are suspicious that we're trying to withhold state-of-the-art care. So Rita and I have known each other for a long time, and I've been a tremendous admirer of her work. And I just think this is one of the harder stories to explain to the public.
Thanks for the introduction, Peggy, and appreciate your comments. And certainly there are challenges to the idea of less is more. And as you said, a lot of our culture is oriented around more is better, and newer technology is always better than older or no technology. But I do think that a lot of people are becoming very tired and not happy with our overzealousness about technology and not really focusing on patients. And while there were detractors, of course, there were a lot of enthusiasts, and we got an incredible amount of positive feedback and increase in submissions and popularity in the Less is More section of JAMA Internal Medicine over my tenure of the 14 years there. And it really struck me how we heard from patients as well as physicians, particularly older physicians who had been in practice for enough time to know and see what the changes are. And I don't think anyone is happy now with not having easy access to a doctor who knows you, who will return your phone calls, who will talk to you. And it's just become so much easier to get a test, but harder to actually talk to someone about your health and what the test or anything else might mean.
Yeah, indeed. So the Specialty Society for Interventional Cardiologists, the Society of Cardiac Angiography, once listed you as a top threat to interventional cardiology. What an honor. Why?
So the reason that it was not popular among some interventional cardiologists was because of my public statements that we should have evidence to support the current practice of interventional cardiology. When I started my cardiology training in the late 80s, balloon angioplasty was approved by the FDA not on the basis of a randomized trial, but on the basis of some interventional cardiologist who was able to show pictures that he could put a balloon, blow up an artery, and the blockage would kind of get smashed into the walls of the artery, and then blood would start flowing. But the FDA did not require any data to show that this actually reduced the chance of having heart attacks or increased the chance of living longer. Almost 20 years later, we got the first randomized controlled trial. By this time, we had stents, the study that compared how people did if you got a stent versus medical management. It showed stents did not reduce your chance of having a heart attack if you had stable coronary disease. They didn't increase your chance of living longer. The only difference was that at 1 year, slightly more people who got medical therapy still reported symptoms, the angina that led to the procedure in the first place, although that difference disappeared by the 3 and 5 year follow-up. The problem with even that result was that this was an unblinded trial. People knew they got a stent and would be told things like, you're fixed now, and shown pictures of now the blood is flowing. So was a good possibility any change in a subjective symptom was related to a placebo effect and not to an actual benefit of the stent. We still couldn't be assured stents reduced angina because the interventional cardiologist said, well, of course we know they don't reduce heart attacks. They don't make you more likely to live longer, but they do reduce symptoms better than medical therapy. It actually wasn't until probably another 10 years a study did a placebo procedure or a sham procedure for stents. It turned out that if you did a placebo procedure, there was no difference between people who got medical therapy and stents. The story is illustrative because it shows how we can be totally invested in a new technology without evidence it's good for patients. And it was the approval by the FDA back more than 30 years ago of the initial balloon angioplasty that spawned the entire field of interventional cardiology. This entire field, which is well established now, was not based on evidence. These procedures are good for patients. Hence, I was considered a threat to interventional cardiology. But it's a sad story for patients and for doctors because until these studies were done years later, there was a lot of belief they were good for patients. Certainly the pictures look better, but it's important to have clinical endpoints in trials and not rely on pictures and blood markers. Why I focus a lot of my research on standards for medical device approval is for exactly that reason. The stents is an illustration of how hard it is to change practice once a procedure or a device gets on the market and we have a whole specialty built up around it. There is also incredible financial incentives to do procedures. As a cardiologist, I would get paid a lot more to do a stent than I do to give someone medical therapy for coronary disease, even though they would do equally well or better by not having a procedure, because any procedure is going to subject you to risks. However, that procedure is done in millions of patients, and interventional cardiologists and maybe others still believe it's good for patients, even though none of the studies can support that. We went about it in, unfortunately, a backwards fashion of first starting to use it and then getting trials that show that there was not a clinical benefit for patients. It's so important to first do the randomized controlled trials, show the clinical benefit, and then move on. So in the less is more series, we focused on what are the harms of procedures that may have little or no known benefit, in what are the percentages of harms, and talk about it because it's not something we talk about commonly in medicine.
Yeah, it's very interesting. I think the psychology of patients, counting myself, if something's wrong and somebody holds out to you the promise of fixing it, it's very attractive and it's very hard to say no to that. And I mean, you're also at an information disadvantage when you're not a doctor. So nobody has to be a bad person here. It really is kind of a very complex model of how these things happen.
I don't think there's bad. It's not a bad person and it's not bad people. And I think in the medical profession, there also is some feeling that we want to do something. So if somebody's sick, we want to do something.
Exactly.
And I think the problem comes that we want to do something even if the evidence doesn't support, but the patient will be better off if we've done something.
I wonder if you could tell us the story of Mary Caldwell and what we can learn from that.
Colleagues had seen this patient who was a middle-aged woman, had started an exercise program and had started lifting weights, but she did develop some shoulder and chest pain. So she went to her doctor, probably partly because of the campaigns we have that any kind of pain between your waist and your shoulders in a woman could be a sign of a heart problem. Her doctor pressed on her chest where it hurt, and she said, "Oh, yes, that reproduced the pain." We teach medical students, if you can press and reproduce the pain, that is not a heart pain. The doctor also did an EKG, and the EKG was normal, did a bunch of blood tests, ran a lipid panel, everything was normal. But instead of stopping there, the doctor said, "Well, just to reassure you, I'm going to get a coronary calcium scan. CT scan will show whether you have calcium in the lining of the coronary arteries." She went for the scan because patients usually do what their doctors suggest. The scan showed she had calcium in one of the main arteries that feeds the heart. So she was then sent for another test, cardiac catheterization. So I'll just say there is no evidence coronary calcium scans improve outcomes or lead to a better outcome, and particularly in this patient who was already asymptomatic. She ended up with a cardiac cath, and her arteries were indeed normal, but she had an unfortunate complication. The catheter that was put inside the artery ripped her artery. She had to go for immediate surgery to repair the hole now in the main artery feeding her heart. She had to have bypass grafting and had a complication of the bypass surgery. The graft closed. So now she had a closed graft and she got a stent. She got a stent with mesh and had to take blood thinning drugs. But despite that, the stent closed off and clotted. And her heart muscle function declined. And she ended up with a heart transplant. And it was all started from a coronary calcium scan, which was ordered, quote, just to reassure her. So that's why talking to your patient is the best form of reassurance. And it is not necessary to get an imaging test and a coronary calcium scan in order to reassure the patient. Sadly, coronary calcium scans have only increased in popularity, and I think they're way more common today. They're advertised widely. They're now covered by a lot of insurances, and the data in terms of benefit for patients is still not there. And these kind of things can happen more and more.
It's a pretty grisly story. NCQA, we try to advance quality. We really don't drill into things like this. We've had attempts to kind of figure out, is there a way to measure when people are doing things inappropriately? And it's just been like hitting a wall over and over again, partly because trying to disprove something is often difficult. And then there's just kind of a mindset often about a determination to believe that this actually is good. That's very difficult to break through. So let's talk about choosing wisely, because the ABIM, I think, very courageously stepped up and said, let's have each of the specialties come up with something. And so can you talk about that, Rita?
It was really the American Board of Internal Medicine putting out there that we needed to talk about the fact that not all things that doctors recommend for patients were necessarily good for patients. The Choosing Wisely campaign asked specialty societies to choose what they called the top 5, say 5 things patients should question or talk about with their doctor if their doctor happened to recommend one of these 5 things. It was very helpful in getting specialty societies to think about those top 5. It was helpful for patients to understand that there were things that they shouldn't necessarily agree to if their doctor had recommended it, because that's very difficult for a patient to say no or to question a doctor when the doctor has recommended something. There wasn't any kind of methodologic rigor to it. The specialty societies didn't, for example, look at the evidence in the literature and say, oh, what are we doing that really doesn't help patients? Sort of a closed door process at the specialty society that came up with these recommendations. I made some recommendations to my own specialty society, the American College of Cardiology, that on our top 5 list should be doing those stents in asymptomatic persons. Well, that was rejected because that was a very popular procedure. Instead, what ended up on most of the lists were things that were not going to make a big impact. They were things that were rarely done, or specialty societies chose things that were done by other specialties, not by their own. But even beyond that, it didn't have a big impact because there was no implementation strategy. So you made a list, but that didn't really change the behavior of physicians ordering the test. I don't know how many patients took those lists to the doctor's office and had a discussion about it. So it certainly was courageous in that it generated discussion. We did publish an analysis of the Choosing Wisely recommendations led by Alan Rosenberg in JAMA Internal Medicine, and they chose a few that they could evaluate and found that there really had not been much impact on practice. And as you know, the Choosing Wisely campaign has ended.
Yes, I do. So let's talk about statin. They're in widespread use. I mean, NCQA used to have measures on use of statins, but you've been critical of the widespread use of statins. I wonder if you could say more about that. Don't they improve the quality of life or extend life?
I don't know that even the biggest statin enthusiasts would argue that they improve the quality of life, because we all know people that have been quite miserable after starting to take statins. They do lower cholesterol, they do lower LDL, a certain form of cholesterol, that's for sure. But the question is, does lowering your cholesterol or your LDL lead to an improvement in how long you live or less heart attacks? And that's where I differ with mainstream cardiology in reading the evidence. Most statins are prescribed for people that have not already had a heart attack or have established coronary disease. In that higher risk group, there is some benefit to taking statins. It's not huge, but there is some benefit. But most people I see and most people taking statins are not in that category. They're healthy people that want to prevent a heart attack and want to live longer. They definitely are not going to feel better. The problem is that after having read all of the studies and all of the meta-analyses and all of the systematic review, the data is just not there that they're helping anyone to live longer. And as I said, these are people who already don't have symptoms. I believe that we should prescribe treatments to people to either help them feel better or live longer. In asymptomatic people, that should be to help them live longer. And statins don't do that. That's why I differ with the cardiology guidelines. I see patients every week who are very low risk for heart disease, are clearly not getting any benefit from taking a statin, are quite miserable and are terrified to stop the statin, but come to see me because they would like to. They're not able to enjoy their life. They're not able to exercise. They're not able to get around. They feel like they're in a brain fog. I generally stop their statin and they feel much better. I, at this point, don't even recommend checking lipids, because the main effect of tweaking your cholesterol panel and your lipid panel is it ends up putting people onto statins who don't need them. It's really important to try to reduce your risk of having a heart attack and, of course, to help people live longer, but I can do that without checking their lipid panel. Most of that's lifestyle changes. It's about a healthy diet, regular physical activity, not smoking, having good social connections, enjoying your life, all these things that are really good for you. None of that requires checking lipids. When I started in cardiology, we just used to check total cholesterol. Then we got LDL and HDL and triglyceride, VLDL. And now I have patients come in with 5 pages of lipid tests that they have had, because there are a lot of these specialty labs that do lipoprotein subfractions. Of course, when you do that many tests, one of them is going to get flagged as being abnormal, and this makes people very anxious. And so, Peggy, it's not just that it's not helping them, but it's contributing to taking a healthy person and making them someone who's not going to enjoy their life as they would if they weren't worried about this lipoprotein subfraction that is really meaningless. So I just think it's sad we're not focused on things that improve patients' health and then stopping right there, not having to order another test just to reassure someone.
Yeah, I mean, the Hippocratic Oath says first do no harm, right? We've said some things that are going to be controversial among some physicians, but I'm always struck by people like you who are so determined that the physicians will rise to the occasion of not doing harm and will try to do the best to have the best outcomes for their patients. But how hard that is at times to have happen. We know that people hate it when their insurance company gets in the way when their doctor wants to do something.
Mhm.
And there are actually some legitimate issues where you would like the patient to understand really what the risks are, what the potential benefit is, and so on. But we're not getting very far with that agenda. People say, well, if we paid for outcomes, then people wouldn't do these things. And yeah, that sounds easy, but it's pretty complicated. And a lot of what drives outcomes isn't necessarily directly related to whatever that intervention was. As a general proposition, what do you think can be done here? So I just wonder if you have any thoughts about a better way to do that. Having your insurance company get between you and your doctor, that's not working so well. It poisons the atmosphere of trust that's so important in
Right.
healthcare.
Exactly. I think the atmosphere of trust is really important. And I think the patient doctor relationship is so important. The doctor who knew you. And
Yeah.
really, when I started in medicine, there were a lot of doctors like that who
Yeah.
I had an experience in medical school. I actually went into medical school thinking I would go into family practice or internal medicine and not a specialty like cardiology, although I love cardiology. But I worked with a family practitioner, Jane Carswell in North Carolina, who did forceps deliveries, which a lot of OBs won't do them because they're very high risk deliveries. And after delivering the babies, she took care of them until the day they died. And she took her own call. She was an amazing doctor. She actually started practicing before Medicare. And she told me at that time, she just used a sliding scale. She kind of had an idea of the income of the patient. And if they could afford it, she charged them more. If she knew they had limited means, she charged them very little or nothing. She would go to the pharmacy, this was before any prescription coverage, and buy drugs for her patients that couldn't afford them. Patients brought, her house was filled with plants and vegetables. She said she couldn't even keep her own garden because the patients brought her so many things. And she was incredibly happy and loved in that community. And part of that went away with fee-for-service medicine because the problem in fee-for-service is that it rewards high volume, but
Right.
not quality.
Right.
And over time, that really led to an incredible increase in volume and not in quality of care and not in talking to patients, because talking to patients or the reassurance, which is, I think, what a lot of people come to the doctor seeking, that this funny pain that just started isn't a sign that something terrible is about to happen. And we've now kind of shifted to where we pay more for tests, we pay more for procedures, we pay more for fancy technology, and we have a lot more of it. There's so much more technology and so many more devices now than there were 30 years ago. And so all of those forces in our system are moving towards doing more, doing more, doing more. And it's why we have by far the most expensive system in the entire world. Yet we have 35 million Americans who are uninsured. We do not live longer than countries that spend less than half what we do on healthcare. And so perhaps we can learn some from looking at countries where they live longer. They have much higher quality of life standards than we do. I mean, so part of it's that we do more. Part of it's that we have more. We have way more CT scanners per capita than any country in the world. When you have a very expensive equipment like a CT scan or an MRI, you want to keep it busy because the more you use it, the more income it generates. And so, unfortunately, medicine, we can create our own demand, right? And so all of that leads to a very high volume inflated system. So I do think we can certainly change, but it's getting harder and harder as there are more and more entrenched interests and so much conflict of interest in medicine now. And I think a big part of it, and why I focus on FDA and device regulation, because as I gave the example of stents, things get onto the market without any evidence that they're helping patients, then they get paid very handsomely from Medicare and other insurers, but Medicare often sets the sort of standard for whether any insurer will cover a procedure. And once something gets entrenched, it's very hard to then pull it back. It's like a speeding train that left the station. So I think FDA reform, which I'm hopeful in this current administration will happen, because I think there is some interest in improving processes there, both pre-market and post-market.
Yeah, maybe it's time. Maybe we can have some hope. I can't tell you how much you are such a pleasure to listen to. And, everybody would like to have a doctor like you, I'm sure, because that heart quality is so, you lead with it. You've dedicated your whole career to cardiology. Anyway, I just want to express my appreciation for you and your wisdom and your character and your courage. Thank you so much for these incredible contributions. And I'm sure you're going to continue to make great contribution going forward. So
Thank you.
Thank you
Thanks,
so much.
Peggy. Thank you for the kind words. I feel very lucky and privileged to have my career and be able to do what I do. I really enjoy the work. It's very rewarding. I really like helping people. I like teaching the medical students and being at UCSF where I can do that. And I feel very lucky to have this career and get to work with so many great people, including yourself, and for your work.
As I said at the top of this episode, this is a tough but essential conversation. Waste and unnecessary treatment are among the most pressing and most overlooked problems in our healthcare system today. Dr. Redberg reminds us that progress shouldn't come at the expense of patients. She's asking the hard questions. Are we prioritizing innovation and volume over outcomes and well-being? Are these new technologies truly improving care, or are they reinforcing a system that rewards doing more instead of doing better? Like all the guests in this series, Rita isn't afraid to push back against the status quo. She leads with courage, compassion, and a deep commitment to her patients. And in doing so, she's showing us what high-quality care really looks like. Not more tests, not more interventions, but more thoughtful, patient-centered decisions. We have to start asking why. Why that test? Why that treatment? What does the patient really want? Technology and access to information have transformed medicine, but they've also created a culture where newer can seem synonymous with better. It's time we slow down and have honest conversations with our doctors, our families, and ourselves about what care truly means. So here's my challenge to you. Trust your care team, but also ask questions. Understand your options. Make shared decision-making. Because when patients and clinicians choose wisely, we don't just reduce waste, we create room for care that actually heals. Thank you for joining us this time on Quality Talks. If you enjoyed this podcast, please rate us 5 stars wherever you listen. We'll see you again next time.